Warning, this video contains graphic content. The following images and/or content may be disturbing to some viewers. Viewer discretion is strongly advised. This is a group presentation for Biology 1322 on the topic of Kwashiorkor, a protein deficiency. My name is Rosa Villa and the others in my team are Kylie Reisman and Noelia Rivera. Keep an eye out for the following vocabulary that will be displayed throughout our video presentation. So what is Kwashiorkor? A dietary protein deficiency disease seen originally in children from Ghana, particularly children 1 in 3 years old. Kwashiorkor's discovery. In 1933, discoverer Cecilia Williams was the first from America to describe Kwashiorkor, the malnutrition disease of childhood associated with a starch-based diet low in protein. Countries most affected. It is most common in sub-Saharan Africa, Southeast Asia, and Central America, and other countries where people routinely have a limited supply of food. The origin of the Kwashiorkor name. The name originates from the Ga language in Ghana, Africa, which translates to the disease of the deposed child, because the disease usually occurs after the mother stops breastfeeding and the child transitions to a diet that is low in protein. Kwashiorkor affects several body systems that result in the following symptoms: edema, a fluid retention leading to generalized body swelling, delayed growth in children, a swollen stomach, thinning of hair, skin depigmentation, frequent infections, loss of muscle mass, flaky rash, and bloating. Those with a protein deficiency also develop apathy, irritability, anemia, fatty liver, and villus atrophy of the small intestine. So the main cause and mechanism of affliction is a severe deficiency of protein in the diet, usually seen in places that do not have a great food supply and also lack of nutritional knowledge. The cause and mechanism of affliction, as we can see in this flow diagram on Kwashiorkor, the body fails to adapt, starting with inadequate protein intake, increases insulin levels, which prevents tissue catabolism, causing essential amino acids not to be available, which cause two main issues with the protein deficiency. On one side, we have albumin not synthesized, causing edema, and on the other side, we have failure to synthesize beta-lipoprotein, causing a fatty liver where the fat is not mobilized from the liver. Diagnosis criteria. Kwashiorkor can be diagnosed from the child's appearance and asking questions about their feeding and nutrition. Laboratory and imaging tests are also performed. Available test. If Kwashiorkor is suspected, your doctor will first examine you to check for an enlarged liver and swelling. Next, blood and urine tests may be ordered to measure the level of protein and sugar in your blood. Other tests may be performed on your blood and urine to measure signs of malnutrition and lack of protein. These tests may look for muscle breakdown and assess kidney function, overall health, and growth. These tests include arterial blood gas, blood urea nitrogen, blood levels of creatine, blood levels of potassium, urinalysis, and a complete blood count. Risk and environmental factors. Risk factors for Kwashiorkor include conditions that interfere with absorption, such as cystic fibrosis, dietary changes for management of milk allergies in infants and children, diets that are low in protein, such as a vegan diet, drought or famine, infections that interfere with protein absorption, limited food supply as may occur during political unrest, parasites such as intestinal worms, poor education about proper nutrition, and prolonged hospitalization or residence in a nursing home. Available treatments. In the early stages, Kwashiorkor can be treated with either specially formulated milk-based feeds or ready-to-use therapeutic food. Hospital treatment involves treating or preventing low blood glucose levels, treating dehydration with specially formulated rehydration solution, treating infections with antibiotics, treating mineral and vitamin deficiencies, and introducing small amounts of food and gradually increasing the amount of food. Risk of treatments. Complications of Kwashiorkor include anemia, coma, frequent infections, intellectual disability, physical disability, poor wound healing, shock, and distorted stature. Average cost of treatment. The International Rescue Committee's treatment of severe acute malnutrition programs costs between $100 and $500 per child treated. The average cost per child being treated was $235, excluding the shared cost of country office management, and $300 when said costs were included. Dietary restrictions of disease. Kwashiorkor can be corrected by eating more protein and more calories overall, especially if treatment is started early. You may first be given more calories in the form of carbohydrates, sugars, and fats. Once these calories provide energy, you will be given foods with proteins. Kwashiorkor can be prevented by making sure you eat enough calories and protein-rich foods. Dietary guidelines from the Institute of Medicine recommend that 10 to 35% of adults' daily calories come from protein, 5 to 20% of young children's, and 10 to 30% of older children and teenagers' daily calories should come from protein. The following is a list of our references for Kwashiorkor presentation. Thank you for listening to our presentation.